So how do I examine a shoulder with calcification? I will tell you how I proceed. First of all, I measure the size in the short and the long axis. So of course we should measure the calcification in the long axis, but also in the short axis. Okay, we need to have estimation of the volume of this calcification in order to think about evacuating or other possibilities. So we need two measures at least of the calcification in the long axis and the short axis. Don't forget that. Second, the tendon location, of course, is important too. We need to know if the calcification is located at the supraspinatus, here, at the supraspinatus. In the long axis, you can see we suspect it's at the supraspinatus, but we are sure in the short axis that we are at the supraspinatus, like you can see over there. In this case, we are going to see a calcification in the posterior part of the infraspinatus, a type 1 calcification, you can see here. And in this case, you can see a calcification at the subscapularis, and we are checking how this calcification relates with the coracoid, if there is an impingement or not. Okay, so location at the supraspinatus, infraspinatus, and subscapularis, and remember teres minor is very rare. Second, the morphology. Is it well defined, this calcification? Is it fragmented? So we are going to have some problems depending on the number of fragments of the calcification if we try to evacuate this calcification. Is it a linear calcification that you can see here? Okay, this calcification in the long axis here is the same and this one here. You can see very, very narrow. Okay? So this calcification, if we try to evacuate, we will find there is no calcium inside. I'm not sure this type of calcification is a calcification or a scar inside the tendon. Okay? But for now, we think there are calcifications.
Welcome to MSKFreak.com. Structured training in musculoskeletal ultrasound from anatomy to pathology. You will find high-resolution images and videos that help you truly understand what you're seeing. Full courses are available on the website.
This is a puntiform calcification, like more or less a type 4 or molecular calcification in the X-rays. Okay, you can see this small calcification, like these points of calcification. It could correspond to an older calcification which is partially reabsorbed, or it could be a dystrophic tendon with these dystrophic calcifications inside. Again, in these cases, we are not going to evacuate calcium from inside if we try. It's very important, the fine classification for me, because it correlates with what I am going to find with the ultrasound and the puncture and the needle inside the calcification. So in this type 1, I'm sure the hardness of the calcification will be terrible, and it will be difficult to get inside the calcification and to evacuate. Not impossible, but difficult. This type 2 will be easier, and still there is some possibility that it could block the needle, so I must be aware. And finally, the type 3 is going to be very easy, and this one is related with being symptomatic a lot. Okay? This one, the type 2 too, but especially the type 3. And in this case, for example, this classification is just about to break into the bursa. So if you find a patient with this type of classification, this type 3 of pharynx, just try to remove this calcification before it breaks, because you will reach a better treatment, better quality of life for the patient. And if this calcification breaks, the patient is going to have bad times, 10 days, 14 days. Okay, so maybe you can relieve this before it happens. Finally, I use dynamic maneuvers. When I'm not sure this calcification is the cause of the symptoms, I move the calcification and try to provoke the pain of the patient. So in this case, the calcification could have an anterior impingement, a subcoracoid impingement, when it passes underneath the coracoracalis muscle. In this case, I ask for the internal rotation and adduction and see what happens when the calcification is under the acromion or under the coracoacromial ligament. If it provokes the pain, then I think this calcification is the cause of the pain, and of course I try to remove this calcification. You can use the Doppler. The Doppler is almost the same as the MRI hyperintensity surrounding the calcification. It tells that there's a hypervascularization, there's a synovitis surrounding the calcification, and a tendinopathy, active tendinopathy surrounding the calcification, and can help us define if this calcification is painful or not. But it's not always present, so it's not constant, this Doppler at the calcification of the shoulder.